Hello, everyone, and welcome back. I'm very excited today to introduce you to a new guest, Dr. Dee Wu, who goes by Woody. Welcome.
Thank you. Thank you for having me
Welcome.
here.
I'm
Yeah.
so glad that you are here. I have so many questions for you. But first, I need to brag on you a little bit, as I always do. So I'm going to start out telling you guys a little bit about Woody. He trained as a medical doctor and completed his residency in Beijing. He practiced as an orthopedic surgeon for several years before establishing himself in Montreal, Canada. And there, because he didn't have enough credentials, he also went to McGill University to get a degree in physical therapy, which makes him a very unique person on the planet because rarely does that happen. So first of all, like, wow for doing that and all of that work. But there you also established yourself in a unique way again. You were the first male to enroll in a pelvic floor course, which must have had heads turning because people typically think of pelvic health as being, women's kind of domain, which is totally not true. And so from there, I think that's, from understanding a little bit about your background is that's where you learn so much from that course. It kind of shifted your whole trajectory. So shifting from, was that course, just to veer from the bio for just a second, because I'm so curious, was it really just female centric? Did they talk about male pelvic health at all?
That course was specifically designed for treating female urinary incontinence.
Okay.
Yeah.
Okay. What year was that? I'm curious.
Oh, that was, 2012, if I remember right.
Okay. Yeah.
More than 10 years. Yeah.
Yeah. Those of us, I finished my PT degree in 1998. And at that time, I took my first job in an underserved area where they almost immediately pointed to me when I got there and said, you're the new kid in town. You're going to go and specialize in pelvic health.
Wow.
Because
So
there
you
was,
started very, very
right,
like
right, there
long
was
time ago. Yeah.
no one. And so my very first course, that was pretty much all that was available was biofeedback, kind of the EMG for urinary incontinence. We weren't talking about managing anything else. So the whole field has come such a long way. And that's why I wanted to bring you on the show today, because over the past decade, you've been drawing from your inspiration in your dual training as both a doctor, a surgeon, and a PT. And so that's allowed you to build this repeatable, reliable kind of structure for treating male pelvic pain. So now, after about a decade of practicing that, you are sharing your knowledge, your passion about pelvic pain nationally and internationally with PTs who are interested in treating male pelvic pain. So once again, welcome and thank you for being here.
Thank you. Thank you for
Yeah.
the introduction. Yeah.
Yeah, absolutely. So I have the very first question that's like burning a hole in my proverbial brain is tell me about what led you to dive into the world of physical therapy after having a successful career as an orthopedic surgeon.
Oh, that's a very good question. I have been asked this question, I don't know how many times. I wouldn't consider my career as an orthopedic surgeon that was successful. Um, I mean, I think I was in it, but I practiced 3 years after I did my residency. But I always felt I was stuck in somewhere. Just in this tunnel, you start to learn treating a person, and then gradually you shift your focus on a joint. That's I think that's the normal route. People have to pick up their specialty. You start from treating everywhere in the body, then you end up treating only shoulder or knee. I think that's my turning point. I start to lose my passion. I just feel like I'm really just dealing with one joint at a time. So, and I think that's make my start to question my career. So I made my move to go to Canada because I think this is where the advanced medical practice, and I think I need to find my answer there. I think that's one of the reasons I left my career in China. Um, so then when I went to Canada, it's just everything seems hard to practice, and I need to get back to practice as soon as possible. So I think at the moment, physical therapy may be something very close to what I did in the past, and probably it's easy for me to get back to practice it. But it's really when I enter the PT program, it just opened up another horizon for me. I mean, it's completely changed my mind to my perception how to manage musculoskeletal condition. And I think this is a bad thing happened to my life. I just discovered there are so many things we can do actually without doing any operation, like invasive treatment. And also in the program, I start to really approach to just a musculoskeletal pain in a more holistic approach. You really have to dive deep to understand what the patient need, how their lifestyle impact on their functional pain. And I think this is just I find myself, oh, this is actually what I enjoy the most, the interaction with the patient, understand what they need. And I think at one point just decide, you know what, I don't want to go back to, just operate. It
Yeah.
was fun, like to operate to fix a problem, but I think I enjoy more to help my patient, empower them, transform their life. Um, the interaction part with a human being, I think I'm craving the most. So then I end up in this PT world, like people don't understand why, But I think I enjoy being a physiotherapy way more than being a surgeon. Yeah.
Wow, that is such a incredible story, for one, and also just to give you loads of credit regarding like the courage that it took to take such a massive step and shift, to not only change careers entirely, but move across the world at the same time. I mean, wow, that's amazing.
Thank you.
Your patients benefit from that, from that courage, because you're putting that energy and passion, um, that was the catalyst for that change, right into their health and them getting better, which I can't imagine having anything more as a superpower than that.
Yeah, I
So,
think that I'm lucky in the sense I was able to see both, and I think that's another. I think there's always a miscommunication between surgeons and physical therapists. I think there are so many things we need to do to connect them. I think I'm lucky enough to see both and I understand both. You know, um, and I think only when you have this chance to see both, you start to understand better. Because if you tell me what PT can do, let's say 15 years ago, I wouldn't believe. I really just
mm,
believe my skills in operation room. So I think that I can fix everything, but the reality is not.
wow, I wish this that everyone could hear that message, because that was actually the question I was going to ask, but you kind of already answered it. I was going to ask, based on your very unique perspective that you have as a physical therapist coming from that physician background, some of those unique perspectives that you bring to your practice and your coursework, um, is is invaluable. And I think that you understanding both sides is one part of that. But do you see other, kind of pearls of wisdom that you wish other people knew or understood about the fact that you have both backgrounds?
That's a very good question. I, I think we just have to stay very open-minded, and to believe, uh, the power of healing in terms of pain or improve function is everything within ourselves. And I think that's if I go back, have the chance probably there will be, I can easily say 50% of the surgery I may avoid or decide not to do that because I think we do that too soon, Um, and, I think I
That's a
don't,
powerful statement.
yeah, I
Yeah,
don't
that's
remember
incredibly
I don't
powerful
remember
thing.
how many times without our decision, for example, do a discal herniation surgery or resect a menisc, or even we try to resect the prostate, if there's issues. And right now we realize that, just there may be what we see from the imaging study or what we see in the operation room there, that's maybe now the real issue. And that's why no wonder we have so many patients after surgery that's still in pain.
Yeah.
And but we just believe, okay, so we solved the issue, but actually that's not the problem. So I think that's one of the my perception. If you can go back, I can tell all my colleagues, we should give more chance for people to heal. And a lot of healing, you know, like probably we already know, it's very simple and very easy and way more cost effective. You don't have to go that invasive and
Yeah.
spending too much money on that.
Yeah, absolutely. The amount of money that's particularly spent in the United States is more than anywhere else in the world, but it doesn't speak highly of our outcomes. We don't have good outcomes, but we're spending tons of money on healthcare. So that brings up the question of what should we be spending, those funds on? And when we look at the evidence, things like mindfulness, aspects of integrative medicine, lifestyle medicine as an intervention are incredibly overwhelmingly beneficial, and yet it's not, at least in the United States, our system is not set up to be congruent with the philosophy of applying integrative and lifestyle medicine. And so people don't get it, they don't have access to it. And drugs and surgery are the very first thing that's offered, which then drives up costs and puts people into really horrible financial situations, here in the US, where people are bankrupted by their medical bills. And in large part, most things that people suffer are preventable.
Exactly. Well said.
So I want to talk to you about what you're practicing now, because you are practicing pelvic health. You are specializing in treating male pelvic health issues, which is a huge underserved area. I'm sure that you can speak to, and it's why you're training now, the numbers that we need, to increase in terms of people available to treat male pelvic health and really pelvic health in general. There's just not enough of us to go around. And I know one of the interventions that you use is mindfulness. But before we talk about that, I just like to give a nod and acknowledgement to, again, what you're doing in male pelvic health, because, and I'd love for you to speak on this a little bit, speak to this, is how many people do you see, men do you see, who have been given the runaround, the brush off, medically kind of gaslit, said, oh, your pain is not real, or there's nothing we can do. How much does that happen in terms of male pelvic health? Because here in the United States, men in the pelvic health who need pelvic health can be medically gaslit just as much as women, and transgender people as well.
Oh yeah, I think that's really reflect a big issue about mental health. And then, there's this story, like I think I saw this guy not very long ago. This gentleman in his 30s, and he suffered this testicular pain for 11 years. Okay, so he has saw, if I remember right, like at least a 6 or 7 urologists at the moment,
Wow.
and no one told him to see a physical therapist. Um, and the last surgeon had to decide to resect one of his testicle and just to. And the sad story is even after the operation, and this patient is still in pain. Like
Mm.
this is, I think, the saddest story I have heard. Like that's in Canada, and that's not, we say, like a 30 or 40 years ago. This is just recent in the last
Yeah.
decade.
Yeah.
I think people still don't understand um, when we have a pain down there, it's not necessarily just linked to the structural or anatomical issues.
Yeah.
And this patient has suffered a lot, lost a job, and has been, like you said, like a soccer ball being kicked from one professional to another, And this is not just a single case. I have seen this kind of case, I mean, in the weekly basis, But I think the situation is getting better. People start to aware, and we have this professional physical therapist can help this patient, who suffer from these issues. So, and that's why, like, I think, I think I found almost like my, mission, or my purpose of life. I really have to speak out for pelvic PT. We can do so many things and good things for men's health and also for the society, for community.
Yeah, absolutely. I know that I had a story. This was also recently, although, like you said, it would seem like it was antiquated, like it happened a long time ago. But this was a young man in his 20s who had been bounced around from practitioner to practitioner, no one really figuring out what was wrong. He had been labeled with chronic prostatitis and, of course, been given antibiotics again and again and again, even when I don't know whether they had actually cultured the, the urinalysis or not, but regardless, he was still being pumped full of antibiotics, which then was messing with his gut microbiome and then making symptoms worse. And the solution that he had been given was just to self-catheterize. And he's in his 20s.
Oh, wow. You
Yeah.
see, that's the sad story. Like 20s, yeah. I mean, like because people they don't understand. Uh, in medical field, we are not trained to manage pain. Like just look at our curriculum. Like I was in medical school. I don't know how. Like we probably spend less than 10 hours talking about pain, chronic pain, in total, the whole career. And when you finish your school, you enter your residency, you have to pick up a specialty. And just think about how many specialists deal with a pelvic, but no one look at everything together. If you have a prostate issue, you have to see your urologist. If you have a bowel issue, you have to see a gastroenterologist, right? You have all these specialties only looking one body part, and that's why I describe it. It's like I don't know if you know the story. Like there are four blind men and try to just get a sense what elephant is, and that's where we were. We are not trained to treat pain, chronic pain specifically, and we are not good enough to put everything together. That's what I hate. My career, like you almost feel like you start treating everything, but then you end up to only treating one joint. But we know, especially pain, chronic pelvic pain, is so complicated, is from the brain all the way down there. Anything go wrong can have an impact on the pain, right? So, but I don't think that's people really aware in the medical community. Maybe right now I think the situation is getting better.
Yeah.
Um,
I wish it would get better faster.
yeah, I hope so too.
Yeah.
But I still think that I see hope. Because I
Yeah.
just see there are more no patient. They have direct access to pelvic PT and just really make me feel happy, right? So
Yeah. One of the things that, in reading about your work that you focus on a lot is that aspect of pain, which can be such an enigma to treat, um, by looking at things like mindfulness. What that seems to be, a lot of what you're encouraging and using, to have practitioners to do. Why did you end up migrating towards that and using it in your work?
I think mindfulness. I think personally I benefit that the most. I think like just we have to be mindful, just about our work. So that's I'm trying to convey the information. Like when I work with a patient, I trying to be aware the person in front of me, what they really need, and just observe what they, not always stay stuck in my mind. I think that's I'm trying to get off, because in the past when I practice surgery or medicine, I tend to believe my my mind. If this patient coming in, I decide to do that, I truly believe that, and I don't think I really consider what patient really need a lot of time, to be honest. But right now, working as a pelvic PT, I'm be mindful. I really understand. Yes, actually, it's not always they have a pain. Just there's something wrong with their mind, right?
Mhm.
They truly experience the pain. They really have that struggle. So I think that's from my practice. Just as a clinician, I try to be really mindful to listen to what patient their need and what they are trying to tell me. And also, I try to get my patient really understand all this pain information, what the body try to communicate with them. I think it's everything just about the communication.
Yeah.
Um, and I even, for example, I even have my exercise I call the mindful masturbation. Like people, and that's a very good exercise. Just build the body and mind connection. And my patient they really enjoy that. They really just felt that before they never pay attention about how the body works during actually sex, right? But by
Mhm.
doing that exercise, they are aware about their mind side, what's happening in the brain, what's happening in the body, what's happening in the breathing. It's just like they just find it's like a transformation of their sex life. So I think, and a study have shown like just being mindful, during sex, that can not only just enhance the pleasure, they're gonna help to have better communication, and you're gonna
Mhm.
have less pain or less discomfort. And
Mhm.
so mindful is just like I think the key for everything, right?
Yeah. Yes, I believe that. Definitely preaching to the choir with that. It's how I began to really full-time use yoga as, an intervention is through that mindfulness gate, because I got thrust into practicing in an area that would become to be in the top 3 hardest hit counties in the country for the opioid epidemic.
Wow.
Yeah. And I couldn't just use what I learned, in PT school. I had to dive deeper than that. And it turns out that lots of people did have that, pelvic girdle area pain, and they were just being fed, you know, oxycodone and never being monitored. And it was in a very rural area where it was already hard to get access to care. So yeah, that area earned a reputation for the wrong thing, but it also catapulted me into a whole different area of my life and practice. So I'm incredibly mindful. And one thing you mentioned too is that mindfulness being for the practitioner as much as it is for the patient, because going from person to person and feeling empathically, their pain is pretty heavy burden that you end up carrying. And to develop your own skills in mindfulness as a practitioner is pretty critical to sticking it out and staying, with the profession and being able to still be effective and not burned out.
Yeah. And I think that's what you said, just really the key point. And I think that's a lot of actually clinician we struggle. I think
Mm-hmm.
this year I give one course in Quebec City, and there's this wonderful physiotherapist. She has treating, you know, women and men who suffer from pelvic issues for 25 plus years. And she just told me, she says, right now I'm treating less and less patient, but at the end of the day, I just feel so exhausted. And and I hear her, like at one point I felt the same thing because the more I stuck in my mind, try to analyze what's going on, the more I feel exhausted at the end of the day. But the more I pay attention to my patient, what they are trying to tell me, through movement testing, through different, assessment, just listen to them and and really let their information guide me to treat them and focus on one thing at one time, and just feel towards the end of the day, I just feel I'm still have a lot of energy. I think the more we're stuck in our mind, the more exhausted we felt at the end of the day, and that's no wonder there are so many wonderful clinicians on burnout, because then we're stuck too much in the mind. And that's what she told me. She's trying to fix like 30 things at one session, but just it's almost impossible, right? You
Yeah.
always have to find the main drivers and just let that to lead you to get one thing done at one time.
Mm-hmm. That's a good way to describe, doing one thing at one time, the difference between being stuck in your mind, which is a juxtaposition against mindfulness, because, how do you be mindful without getting stuck in your mind? And that was actually a question, but then you started to answer it with the doing one thing at one time. Describe that a little bit more, like if you were, talking to the audience as if they were a patient, explaining that concept between mindfulness and also not getting stuck in your mind.
Oh, I think, okay, that's just for me. Like, I think the majority of the patients that come to see me um, is male pelvic pain, just, in the sense like they can have a pain in the testicle, in the penis, anywhere down there. So, because if you think about the structure, like that's what I told my, people come to do shadow work with me. I told them, just think about the pelvic structures. You can have like almost, you can say like easily 100 things can go wrong. All the structures, different muscle, tendon, ligament, nerves is really complex, structure. So, but as a physiotherapist, we really don't have the, you know, it's just impossible. You're gonna differentiate with our hands of all the structures one by one. It's just almost impossible. How are we gonna differentiate this nerve with the other nerve? Okay. And if you're stuck in that loop, just trying to figure out the pathanatomical model, that's where we're gonna get exhausted, because
Hmm.
anything can go wrong, but we don't have the way to differentiate. So that's why I shifted my mindset is, rather than focus on finding what structure is going wrong, but actually what can turn off the pain. So we all know when you have a pain, that's experienced in the neural system. Okay, so from the brain to spinal cord and all the nerve, peripheral nerve, and to the nerve endings. So anything actually can influence the nerve function, have the potential to turn on the pain and have the potential to turn off the pain. So if you think about that way, and it's going to be easier, right? So if the patient coming in, they say, my pain is turned on by after prolonged sitting, prolonged standing, or even bending forward. And there's the posture, the movement can have an impact on your pain. But if the patient tell you, I have a lot of pain when I have a strong urge to urinate, or during the peak ejaculation, that's the pelvic floor activity actually can turn on or turn off the pain. But if a patient coming in say is after taking hot shower, or if I eat spicy food, if I'm stressed out, if I don't sleep, I have way more pain. So there's something you need to address in the central nervous system. So rather than focusing on what structure can go wrong, but focusing on what's the information you know the nervous system try to communicate with you, to analyze what turn on the pain and use that information. We're gonna design the program to turn off the pain. And that's what I found like my way. It's just easy to get, right? So then that's for me, like the patient coming in regarding their complex history. My focus on try to focus on what intervention I can do, working on the neural system, try to turn off the pain. So that's just like my framework to treating men with a pelvic pain.
Yeah. So I think that, if I'm hearing you correctly, it really sounds like the underpinning of the framework of how you approach treating pelvic pain. Really.
Yeah,
Yeah.
exactly. Yeah. So for example, there's someone, you know, they coming in with pain after prolonged sitting or standing, right? and they don't have a lot of influence after, let's say, urination or during sex. So I know the main target is going to be in the spine because that's what's happening in the spine, right? When we have a prolonged posture, prolonged positioning, that's where we get the most stress. Then as soon as we manage that, patient will experience a rapid change in their pain. So sometimes patient coming in, they're in pain, and by the time they left the clinic, the pain already goes to zero. The pains turn off. Just that easy if you really understand what's the pain trying to communicate with you. Use the information designed, you know, the program.
And I think that is kind of the secret sauce of what makes a clinician really effective. If you're listening and you're looking for a clinician, or if you are a clinician, I think that the harnessing the power of mindfulness and being able to approach things with a broader, we all often toss around kind of biopsychosocial, which I don't really like using that word a lot because it's kind of lost its meaning in the clinical world. And of course, in the real world, people are like, I don't care what biopsychosocial is. I just want my pain to go away, right?
Yeah.
But if you're listening as a patient, you want, like, what are you saying? You want to be heard by your clinician. You want them to ask about all of the different positions and the reasons and the hows and the whys of when it happens, because that's how you can construct a very prescriptive, individualized program. In other words, if you feel rushed by your clinician, then you're rushed. You have a valid feeling and a valid point, and that's a good moment in time in which just to say, is this clinician right for me or not? So finding someone who does practice mindfulness, finding someone who does value what you're saying, and that's the power of listening to someone's story and listening to them carefully. It can make all the difference in the world. It especially is effective when it comes to treating persistent pain.
Yes, exactly.
Yeah.
I think that's a secret power,
Yes.
mindfulness.
Yes, it is. It's honestly, it is the only way it saved me from actually leaving the profession, because when you were sharing some of the, stories about trying to just look at things from a pathomechanical model, I think that is unfortunately what is taught a lot of the time. And if we only, like you were saying, if you only focus on that, it is easy to get burned out. It's easy to actually end up with the same persistent pain you're trying to treat in other people,
Yeah.
because you end up thinking this particular manual therapy is the secret sauce, and then you end up with your own back pain or your hand pain because you're doing so much manual therapy, because you're trying to fix people when within themselves they have the power of really shifting their pain experience. So this is my plug, everybody that's listening. This is my plug to go out and practice mindfulness, which doesn't necessarily mean meditation. Mindfulness is a type of meditation, but you don't have to put the two together. It can mean a lot of different things to a lot of people, but it's also a call to action for practitioners to pick it up in some way that's beneficial. And certainly if you treat male pelvic health, looking into Woody's resources, which we're going to share later on in the program, is a good idea. So here's a question, and it's more of the psychosocial aspect, because we often talk about kind of the hard science of what we're looking at in pelvic pain, male, female, all genders. But there's the other part of where pelvic pain is impacting your partner, your family. It's like pervasive into your world. Tell me about how you see the influence of male sexual pelvic health has on, everyone, their partner, and vice versa. Because I'm sure you hear maybe that is part of the most stressful thing to that person, is that it's impacting someone else.
Yeah, I think that's very, very important question. And that's why I think when the patient coming in, and the last part of my history taking, I always do, I call it H.A.P.P.Y screening. H.A.P.P.Y is acronym I use just to gather as many as information as possible to just understand, psychosocially how this person is. So H, it represents like a history of abuse, including sexual abuse, substance abuse, and then A is their attitude, and the first P is perception. The second P is partner, and that's why, we can get a lot of information about what's going on in the family. And then right after the partner is I, is intimacy. So after that, the M.A.L.E, M represent the mood, A is anxiety, and then we have lifestyle and the environmental factors. So I will do a H.A.P.P.Y screening, and from there, and I know is immediately, how how much the risk of this patient is actually involved a lot of psychosocial factors. And then one of the factors you mentioned, the partner. So from there, we hear a lot of stories like actually partners is a contributing factor, you know, in the pain. So for example, I have this patient, even this patient have pain, sometimes he felt better, but his partner will encourage him, oh, you know what, you are in pain, let's now do having sex. So you see there's a lot of interaction between the partners. And actually, just because of that, and I think this is really prevents certain patients to go back to their function activity as early as possible. And sometimes we also know when men they have a pain or they have a sexual dysfunction, there's also highly likelihood their partner is suffering from sexual pain or dysfunction. So, and it's always nice to get a partner involved. Sometime in the past I have to have a couple session. We have this therapist in the clinic. We work together with a couple, so we have to bring them together to really understand, what's their need, what their concerns, and you see that sometimes their pain is getting better, but just the last part, how they go back to their full function, it's just there's something stuck there. You have to get their partner involved.
Yeah.
So yeah, and I think this is just so huge. Just having sometime when we give some treatment, sometimes I give patient treatment, and I will get the partner coming in and to see how I treat my patient, and then he or she will do the technique with them. That's just change another, it's really changed the efficacy of the treatment.
Yeah, yes. I have, I'm just thinking of a couple that I had, and we had ended up doing a video on a model, of course, and too, so that the partner could eventually come in, but could learn a little bit about what that technique is, because this is kind of part of the softer side that can make or break your success in treating someone. Is, do they have that support at home? Do they have someone that could help them, if necessary, destigmatize everything that is taboo or that people don't want to talk about or that are uncomfortable talking about, and just normalize that experience and say, yes, we often teach partners how to do, techniques. Yes, sometimes you come in together. Yes, that may look strange in the beginning or may seem, weird, but it's actually a normal part of the pelvic health process. And then it allows people to just go, oh, okay. Well, and sometimes it takes longer for them to say, oh, okay. But once they can normalize it and just destigmatize it, it's very freeing for people. And maybe sometimes that's part of the secret to success too.
Yeah, I think I think this is society issue. Like, I don't think I always told my, people, I said, like, man, we are emotionally constipated. So we just don't know how to express themselves.
Yeah.
And I think especially in terms of sex, and there's this performance-based, the sex, like we have this perception, men have to perform, men have to have a spontaneous erection all the time. More they can get easily aroused. Man, you cannot having this pain during, sex. It's just like, I think there's a lot of things going on, in terms of our cultural like belief,
Yeah.
taboos, and that's in my practice, I see so often people, they even don't tell their partner they are in pain. They
Yeah.
secretly come to see, professionals, but their partner, they don't understand what's going on. They don't express they are in pain during sex. They force them to perform during sex.
Mm-hmm.
They don't want their partner to know they are taking certain medications, but for example, Viagra. They don't want to felt they're incompetent to, perform. And actually, this is going to cause even more stress, even more anxiety, more
Yeah.
layers on top of layers, and just men, they're suffering. Like I have a man. He's a very strong man. You can see from outside, and he literally just break into tears when I mentioned that. He's like, "Have you mentioned that to your partner? You are in pain?" And he just said, "I can now tell that. I don't know even how to express that. And you are the first person I tell I'm in pain.
Wow.
I have pain in testicle.
Mm-hmm.
But that's really the big problem.
Mm-hmm. That is like makes my heart, kind of squeeze to hear those stories because, and I'm hoping that, this conversation and many others like it that are happening and in the trainings that you do and in the patients that you see, that we one by one can destigmatize and just give people permission to talk about these things. Instead of thinking that A, no one else has the problem, so it's only them, or B, it's something that must happen to everyone at some point and they just spontaneously get over it somehow, or they have to suffer through it. Um, so one of I think the questions that I've read about in your work that I would love to ask you about is the 4 horsemen of male pelvic pain. Tell me about
Yeah.
that.
Oh yeah. So I think this is really what changed my career. Like initially when I start practice, treating men with pelvic pain, and I think we always have that issue. Like I think I have like imposter syndrome. I just think about I'm not good enough. So I took a lot of courses, and a lot of courses just focusing on, specific, techniques or whatever. So then I applied the technique in to my practice. I found it works for a bit, and then it stopped working. So then I stop taking course for at least 7 or 8 years. So then I start to really just put all my patients together, like one case at a time, and really analyze what's actually the pain behavior. So that's really correspond to 4 horsemen. So the first horseman, I call it spinal horseman. Okay, so that is the patient coming in. Their pain will be driven by certain posture or certain movement. And the key things, like for this type of pelvic pain, they change so quick. This is a patient coming in, they experience their pain even like for years, and you can have a very rapid change within just a few sessions. They get off like your office, you know, they're in pain. The second time they come back, they say, oh, 75% better. So this is the type, the type one, like first 4 horsemen, like I saw spinal horsemen. And then
Mm-hmm.
the second group of horsemen, I call pelvic horsemen. And that's the people coming in, you know, their issues rely on is the pelvic floor is not working in the right way. So their pain will be triggered by certain pelvic floor activities. And that the group, we need to really re-educate the patient how to use their pelvic floor in the right way, train their pelvic floor to be stronger, more functional. And they always felt there's this type of patient, regardless what we do, just they are not responding well with either movement exercise, or they are not responding to pelvic floor retraining. They are more complicated. I call it the neural horseman. That means is dysfunction nervous system become the primary driver. That's you really need a more holistic approach. You really have to understand which part of the neural system you need to change, right? So that's the third horseman, or called neural horseman. And then we have someone coming in with clearly injuries, for example, after a trauma or after surgery, or certain conditions, for example, Peyronie disease. they come in, they have a clearly inflammation process, like tissue or structural related. So that's I put them as the last horseman. So and I started when I see that, so when the patient come in by taking history and do physical examination, and I will immediately can sense which horseman I'm dealing with, and I will educate my patient based on what I think is the cause, educate on them on prognosis, what's a treatment plan. And I think just this has really changed my practice and make my life easier and make my patient life easier. And that's what I'm teaching for, people treating. You need to classify the patient, you need to differentiate the cause. And based on where's the main driver of the pain, and you design the specific treatment, just way more efficient, effective.
Yeah.
So, and you get, consistent result. And then when you meet a certain case, it's so complicated. And even it's complicated and you know why it's complicated. It's just like, you know what's the reason,
Yeah.
So I think that's all about mindful things to see
So,
each case. Yeah.
so to recap, I think that's a brilliant way of looking at it. You have the spinal horseman, the
Yeah.
pelvic horseman,
Yeah.
the
Horseman. Yeah.
neural horseman, and then the last one is the
Tissue horseman.
tissue
Yes.
horseman, because that explains that can really lump into everything that's happening in the tissues. Can be environmentally driven, systemically driven in terms of inflammation and other things that honestly people don't often think about. So it's a way that you have to sit down and go, yes, inflammation can drive your pain. Maybe some of the endocrine disruptors you're taking in your environment can influence what you're experiencing. Certainly influences pelvic floor health and performance, that's for sure. So I love that model. Thanks for sharing that.
Thanks.
Yeah. So one last question, because I think this is a really good way to shore up our time, because men are gaslit who have pelvic pain. It's kind of a full circle question. And the question is this: in what ways are men typically gaslit in the healthcare community when dealing with things like erectile dysfunction and pelvic pain?
I think the erectile dysfunction, this is, we all know, like when people having pain, you have a higher chance to suffer from, erectile dysfunction. But also, I think this can happen the opposite. That means people having sexual dysfunction, they have a higher chance to having sexual pain because they want to perform. I have seen many patients, they start from erectile dysfunction, they have difficulty to maintain erection, and then they start to really force them to squeeze, to breathe, during the sex, actually developing pain. And so when patient, I think that's the two major population I see in the clinic, either pain or sexual dysfunction. And I think sexual dysfunction is way more complicated. And there is this, it can be organic causes and can be psychogenic cause and can be even mechanical issues to need to address. And that's another framework I'm trying to use. You really need to see, just I always tell my patient, erectile dysfunction is not a penile disease. So forget about just treating the penis. You really have to, you manage erectile dysfunction is almost you manage the whole person, the whole health. It's just like small mirror reflect on their health. And I think there's a lot of men right now struggling in this society. I mean, study have shown in 2 years, that's mean 2025, there will be about 332 million people, men, in this planet suffering from erectile dysfunction, and just way more complicated, like environmental issues, changing of hormones, all different stress, all this social media, all this even linked to pornography addiction, are just like so many issues actually impact on our sexual function. And that's what I think that's, the information. I think we are probably the best professional to manage the pain and sexual dysfunction, because I think we really see the person as sitting in front of us as a person. We manage that, you know, in a holistic way. We don't see anything just structural. And I think
Yeah.
one of the sad thing I see in this society, we going more and more tissue and organ specific treatments. For example, you see a lot of right now they designed just target the penis. For example, shockwave therapy, injections, all these surgeries. I don't against this kind of treatment, but they just cannot only focusing on that,
Right.
right? And I think that's,
Mhm.
as a pelvic PT, I think we are the best professional to bring this back to the right track. We need to manage the patient. We have to see. I think erectile dysfunction, sexual dysfunction is really just a mirror of the whole health of this person sitting in front of you.
That is probably that's one of the most powerful statements that I know I'm going to take away from this interview, and it's a great place to to end here, because it tells everyone that if you're having this issue, it's not about a particular drug or surgery. If a clinician is not looking at you as an entire person and all the things that you just listed, with lifestyle, which could come down to sleep or environmental disruptors, like we mentioned, the support that you have. It's not just about a movement or an exercise or a type of treatment, even though you may include all of those things, in your treatment plan. It won't be about just one of those things. So I love ending on that quote that having sexual dysfunction or ED or pelvic pain is just a mirror of what's going on inside the entire person and their human experience.
Exactly.
Yeah. So I want to thank you again for just coming on the program and just being here to chat through topics that are often shied away from. People aren't comfortable talking about it. And when they are, they're also not taking such a well-rounded approach like you are, with having just an organic lens that you're looking on the person as a whole being. So thank you for giving us and bringing us that perspective very much. And before you go, I have one random question. um, the random question is, are you reading or listening to any book or album or song right now that's just really, it just turns up the mindfulness gain a little bit for you, and just is a chill pill?
Yeah, I think like recently I'm reading a lot of book about neurotransmitters. Like I think this is just something so fascinating. Like I'm become a bigger fan for dopamine.
Ah,
I think in this society right now, like we all have some sort of addiction, and that's the dopamine, right? Is work
mhm.
that's we all have dopamine issues, I think. And I think like being mindful, just really realize, we have this two system you know, to to function. Like we have this dopamine system, but we have oxytocin, we have endorphins, we have the other molecules like to serotonin, like that. So I think that's when I read it. I think there's a book called Dopamine Nation. That's the book I'm reading right now. I think
Oh,
I
thank
really
you.
love that, and just to see that how you know you need to have the two system to work, and you sometimes you have to embrace the pain, right? You cannot just always driven for the pleasure. We just have to realize that if you always go for pleasure, you're gonna have a long-term pain after. So that's about. So I think like when we start to realize that, everyone is the same in this world, we're gonna have up and down, and just embrace that, and be mindful when you are up. You have to align everything you do with your values, and then when you are down, you realize that everyone have a down moment, and then we just have to be mindful, enjoy the present small things, So I think that's the book right now I'm reading, and happy to share.
Thank you. And I have to laugh out loud because as soon as you said it, I'm like, of course Woody would be reading an ultra nerdy, sciency book. Of course, now I'm going to have to pick it up too. But of course you would be reading that because, you're in that wonderful space that I love to collaborate with other people in. And that's a big room where you above it, if it had a title, of the name of the room, it would be like lifelong learner. You're in that big space. And so thanks for giving us that book. I think it's going to be a good one for other people to pick up too.
Thank you so much for having me.
Thanks for being here.